Good morning. My name is Abram Edgar. I am part of Team Nexus. I'm here to talk about our final project, the patient readmission risk stratification application. I'm going to be the only one talking today. We have a few issues with different time zones and people traveling, so I've kind of compiled notes. But other members of Team Nexus are Gurman Gill, Benjamin Yang, Gordon Jung, and Harissa Dean. So our conversation today is really going to be centered around hospital readmissions. So what is a hospital readmission? So it's generally defined as an unplanned subsequent admission of a patient to a hospital, typically within 30 days of being discharged from initial indexing stay. That's typically another inpatient stay. In some measures, it could be an observation or something else. But basically, did they go back to the hospital in the next 30 days? It's a key metric used to evaluate healthcare quality and indicate potential issues like post-discharge care or care coordination or inadequate initial treatment. So most cases or most causes of hospital readmissions are often categorized into clinical conditions, right? So an individual comes back because they got sepsis, right? Or pneumonia. But it could also be some care coordination and system level gaps in care, or sometimes social determinant factors. So a lot of different things that can drive readmissions. But what's the problem, right? Why do we need to find a solution for hospital readmissions in the United States? In 2020, the US spent about $60 billion that year for 30-day readmissions. To put that in perspective, that is about the GDP contribution of Vermont or Wyoming. It is enough to pay the salaries of about 700,000 registered nurses in the country. It's also $12 billion more than the annual budget of the NIH that funds most of the medical research in the United States. And if you paid me $1 million every single day, by the time I got to $60 billion, I would be 164 years old. So obviously a monumental amount of spend around readmissions. But again, what is it symptomatic of? Symptomatic of critical gaps in discharge planning, care coordination, patient education, and initial quality in the hospital. So there's obviously a need here, but why is it difficult, right? One, it's very, very difficult to understand who is going to readmit, right? Tons of different factors means tons of different information, which means clinicians are faced with information overload from their portals, from their EHRs, and it makes it incredibly difficult to prioritize high-risk patients for a critical 10-day post-discharge window. So that's the problem. That's what our team decided we wanted to take a stab at solving. So the solution is our application, the patient readmission risk stratification tool. And what this is and what makes it different, it is an AI-driven risk stratification engine specifically designed for medical directors, for nurses, for care managers. It's a two-part system where we utilize XGBoost, so a boosted decision tree machine learning model. We utilize that for its predictive readmission probability, so the empirical evidence that somebody is going to readmit within 30 days. We utilize the EHR, so we utilize the FHIR resources for deep clinical context that we can then feed into a clinical agent that we've designed in OpenAI's GPT model with all of the clinical context in the context of the key risk drivers in the machine learning model, right? So you understand who is going to readmit with the machine learning model, and then you understand why they are going to readmit with your AI clinical consultation. So this application, it creates a queue. You can imagine I'm a care manager coming in and I need to see my 10 cases to work through for the day. It prioritizes a queue of high-risk discharges, right? And it really allows us to focus in on what individual needs to be called in the next hour and what patient can be called next week. About me personally, so I'm a data scientist. I've worked about 10 years for different healthcare systems, for different payers, and I've developed a lot of risk models in the last 10 years. What makes this application different, right, than my past experience? One of the big things is meeting the end user where they are, which can also often, be difficult. We always want to go and, bring in some like AUC curves, right, to talk about how great our model is. But we really need to bring everything, especially like the risk drivers, into a clinical context and build a plain language clinical narrative for the end user. So it's very hard to come in and just talk about your SHAP values and your top predicting features and then expect the end user to develop the actionable insights that they need, right? This application does exactly that. So it bridges that gap from seeing the risk score to understanding the risk score. It provides a holistic view. So in addition to the risk, or in addition to all of the features we have that drive risk and create a robust, well-fit model, we're synthesizing all of that FHIR standard data, including medication history, encounter history, the conditions they have. There are even granular information around SDOH needs, right? So we store that in a clinical context, JSON file, and we are supplementing the AI prompt with all of that information in the context of our readmission risk modeling. And again, specific actions. That's really the key here. Everybody I've ever worked with wants to understand their strategic recommendations served up on a silver platter, and that's what this application does. So decision support. This application recommends specific interventions, such as medication management or following up with your specialist or connecting with a behavioral health specialist. Very specific to the needs, not only with what drove the risk score, right, but what clinical insight that agent is able to provide with all of the clinical context that we're able to give it from the EHR data. So we really love this format. This is one of the reasons I love the adoption of AI in my job, is really around that explainability piece. But we obviously do have some limitations, right? And then in the future, if we could find the resources to pick this back up, I feel like there's a lot of scaling and expansion that we could have with this application. But talking about a few of the current limitations, one of the biggest things is the dependence on synthetic data. It lacks the messiness of real world data. It lacks the nuance of actual clinical data. And why does this matter? It matters because our readmission risk model is excellent at finding patterns in things. And synthetic data is built solely on patterns to follow or mimic kind of like high level real world KPIs. So if this member has a admission with chronic heart failure, they are obese, they are over 70, then make them readmit to create synthetic data. Well, our readmission risk works that back and says, okay, well, if they're above this age, if they're obese, they have chronic heart failure, then they're going to readmit, right? So we get excellent predictive accuracy out of the model, but out of sample, probably not going to work that well. The other issue is the messiness is valuable, right? Because there's an entire layer, obviously, like you spend most of your time cleaning up your data and making it clean, making it model ready. Well, we didn't have to do that with the synthetic data because it's already fairly clean. There's no missing records. So, where do you go from here? It's one of those things where you're like, you need to show it's hard to show the efficacy of the application with synthetic data, but to get access to the data that you need to show the efficacy, you need to first get people to buy into it. So you're in a little bit of a catch-22 there. But yeah, future directions. So we'd love to see it integrated with real-world clinical data and EHR. We'd love to see this scaled. So both vertically and horizontally, this application could be easily scaled to create an entire care management system. So there's no reason you couldn't take this same format and expand it to avoidable EDs or avoidable admissions or MSK-related disease progression, right? So who's going to get a knee replacement? So it really could be built out into an entire suite of robust risk modeling with specific clinical consultation, standards, baselines, right, and recommendations for next actions. So we're going to jump over into a really quick rundown in the application itself, right? I want you to kind of like put on your care manager hat. I've just sat down, I've got my coffee here. I'm looking out at my top 10 high-risk discharges from the last week. And I'm going to go through and I'm going to evaluate what we should do, next best action for these. So coming down, you're going to see I've got 10 here, right? All of them extremely high risk to readmit from the model, above 93%. We've got individuals who admitted for COVID-19, for CHF, for aortic valve stenosis, right? So we can see why they admitted. But the real magic comes when we select down into some of these individuals. So we're going to look at Horatio Kaleido. So we're now led into the patient risk dashboard for Horatio. So we can see he's a 98.1% chance of readmission. His top risk drivers in terms of feature importance in our model is his active condition count. He has 28 complex conditions, right? In the last year, he has 78 outpatient visits. Now, what this is, we don't have that level of detail we do in like the clinical context, but 78 outpatient visits. Age at admissions, he's elderly, he's in his 80s, right? All of these are increasing risk factors. But beyond that, we get this clinical consultation summary. And so as you read through this, it's combining the feature importance in the model with Horatio's clinical context. So you can see in this clinical narrative that he's elderly. He's obviously got a cardiorenal metabolic issue, right? He's got diabetes, he's got chronic heart failure, he's frail, indicated by the use of a wheelchair. So he might have transportation issues, right? So he might have trouble getting to an urgent care facility. So he's calling an ambulance to come pick him up. So it's using that clinical context that we have high level detail for the AI model. And then it recommends actions. So let's get a comprehensive care plan here. Let's look at home health services. Let's educate him on his cardiorenal metabolic status. Let's figure out some sort of transportation assistance, right? Let's manage his meds, right? All of these levers that could be pulled for Horatio, it lays out, in recommended actions. On top of this, we have some supporting tools. So we can view the timeline for Horatio. Viewing the timeline here, we can see a history of his most recent encounters. So he recently had an inpatient visit. That's something we might want to look into. If this is a readmission on top of a readmission, that increases the probability for readmission. A lot of emergency room issues here. So we get that timeline of his most recent history because recent encounters, right, predict the future significantly more than just looking at averages. Not only that, we can look at granular details around Horatio. So we can review his meds, right? We can see if he's taking his GDMT meds for his chronic heart failure. We can look at other confounding comorbidities that he has. He has a transport problem. He has hypertension. He has appendicitis. We can see all of these conditions in his details. We can see his allergies. We can see what medical devices is. Again, he's frail. All of this is packaged into a really strong clinical narrative that can be easily exported. It can be taken with them as they're doing their rounds. So this really empowers the care manager to have everything they need to make a decision around Horatio that's best for him and provide a concrete action plan that's really going to impact the next 10 days, the next 30 days in terms of keeping them happy, healthy, and safe at home. I know we're right at 15 minutes. I'm going to have to cut this off, but I really appreciate the time here. A really fun project. Thank you to the team. I point you to the paper, the links in the GitHub repo, and the link to the application itself for any further review. Thank you. Appreciate the time.